Begin by making an incision in the simulated skin pad or pork belly provided. We will now close this with interrupted sutures. With a suture in our needle holder, insert the needle at right angles to the incision using counterpressure from the forceps. Rotate it through gently without snagging it. And then secure a standard reef knot, either using a hand tie or the instrument technique. Note that here we are using a monofilament suture which tends to slip with the first throw, and thus the surgeon has opted for a surgeon's throw for the first two sutures. Because it is a monofilament suture, 6 throws are required. As a rule of thumb, the distance from the edge of the wound should correspond to the thickness of the tissues being sutured. Each successive suture should be placed twice this distance apart, approximately double the depth of the tissue being sutured. Continue to insert sutures across the entire wound. When the incision edges are as closely aligned as these, it is appropriate to go through both edges with one smooth movement. Note that edema will occur in the few hours after operation, making the suture very tight, and if too tight, necrosis may ensue. We are aiming for approximation, not strangulation. The passage of the needle through the tissue is made by a combination of forward movement together with rotation from supination of the needle holder. Forward movement together with rotation. If there is supination without forward movement, the needle will bend. Cut the suture to such a length as will allow it to be grasped for subsequent removal. Not too long so that it gets caught in the next stitch or the dressings, but not too short as it may unravel. Once the wound is closed, ensure that none of the knots lie over the suture line. When removing the sutures, grasp the knot with forceps and cut the suture as close to the skin as possible so that no contaminated suture passes through the tissues when it is removed. Mattress sutures can be inserted to allow for either eversion or inversion, and can also be used for irregular skin edges, or as this suture demonstrates, where one side of the wound overrides another. We desire approximation of the wound edges, and with this stitch, approximation has not been achieved. So we will therefore demonstrate a vertical mattress suture. The suture is first put in, as you see, in the standard manner. The needle reversed in the needle holder, and then 2 small bites going backwards are taken, taking just a few millimeters of the skin edges. A reef knot can then be tied. A second vertical mattress suture is inserted. The first suture placed, the needle reversed, and then returns, just taking 2 or 3 millimeters of the skin edge. The knot is tied, and the suture then cut. Let's insert just one more. In at right angles, out, reverse the needle, then return, just taking the wound edges. Well, here he has taken rather more than the wound edge. The problem with this is that when it comes to removal, there is hardly any gap for the suture cutter to come in, whereas with the first 3, they can be removed in much the same way as we remove the simple sutures. Difficult and probably painful. We're now going to close the same incision using a continuous suture technique. Insert the first suture as before at right angles to the skin edge. And tie using a standard reef knot. In this situation, just cut the short end and pass the long end to your assistant, who will follow you during the procedure. The second suture is put in a standard manner, but the entry point is closer than usual to the first suture. The suture is snugged down and then passed to your assistant. Here comes the third suture, the distance apart being exactly the same as for interrupted sutures, with of course the exception of that second suture we've already placed. Work along the wound, each time ensuring the same tension, and hand it to your assistant who maintains that tension. Continue to work along the wound, ensuring equal distance between the sutures to ensure that the same tension remains down the whole length of the incision. After the final suture has been inserted, leave one loop long and then tie using a standard reef knot technique. Once this has been tied, you're in a position to cut both ends of the suture material. The same principles apply to the removal of continuous sutures as they did for simple sutures. Avoid pulling the exposed, dirty material through the wound, but cut each loop of the continuous suture close to the skin entry on one side, and remove each piece of the suture from the opposite side. Never cut the suture at one end, and attempt to drag the entire length of the suture down the wound. We are going to use a monofilament suture, as it gives a better cosmetic result. An absorbable suture wouldn't have to be removed, but would give some tissue reaction. Start the subcuticular suture by inserting the needle about 1 centimetre from the end of the wound in the line of the wound. With a subcuticular suture, the material never enters the subcutaneous tissue, unlike the other sutures we have seen. Then, using the forceps, carefully retract the skin edge. Take a small bite of the subcuticular tissue and draw the suture through. Then, on the opposite side of the wound, insert a similar subcuticular bite of the subcuticular tissue, and gently work up the wound, ensuring that each bite doesn't go too deep into the tissues. The accuracy of the placement of the sutures will ensure an equal tension down the wound and neatness of the closure. You can see here a needle going in just at the skin edge, taking a bite of the subcuticular tissues and coming out at the skin edge. Each new suture should be inserted almost opposite the exit of the previous suture, and this ensures that as the suture material is tightened, it draws the wound edges together, almost in the manner of invisible mending. At the end of the incision, the needle can be brought out 1 centimetre away from the edge of the wound and cut. We will cut the two ends fairly long and allow the tissue tensions to hold it in place, aided by a tape dressing.